If there's something we've been told for the longest time, is that osteoarthritis is just kind of a wear and tear disease, right? It's an inevitable part of aging. It's just going to happen. What if that was completely wrong? Like, what if we were wrong about this? It's not necessarily this old passive mechanical breakdown, but what if it's an active inflammatory and metabolic disease that we can actually like treat actively? Well, today we're diving into kind of this massive paradigm shift for how I've thought about osteoarthritis. We'll talk about the subsets on them, understanding joint pain, moving away from a model of helplessness and learning to get to an actionable biological intervention, hopefully. So, spoiler alert, there's a lot of nuance here. This is going to be a little bit longer, probably. This is going to be a little more nerdy in detail because we're kind of still uncovering these mechanisms. But I wanted to at least talk about it, right? Because this is something as a sports doc and as a person who loves lifestyle medicine, like these are overlapping themes of, hey, this is not what we thought it was. And so it's a little different. So we'll kind of run into it here. So first and foremost, let's deconstruct this wear and tear misnomer, right? So for decades, we've been sold this engineering or biomedical model view for joints, right? That as we age, the parts are just passively breaking down and wear and tear, and like that's what's happening. And so we're going to dive into why that may not be the case. So the old biomedical model, the model is arguably the primary reason why we have no real treatments for OA right now, right? So we've kind of thought it was just this passive mechanical process, right? It's just something we can't fix or do anything about. It's just, hey, you have it, that's what's going to happen. And it kind of implied that the only things we can do are palliative for it, meaning pain relief, physical therapy, injections, or end-stage surgical treatments. And it kind of leaves no room for anybody actually modifying or treating the disease. Currently, that's where we're at, right? Most people say, hey, you have pain, like we're going to give you some injections to help with your pain or do this, but like we haven't really thought of how can we help the actual disease. It's just kind of been, hey, let's placate you, let's help your pain a little bit. And that's where we've been and hopefully changing that paradigm now. And this old model fails to account for a lot, right? So specifically like the high prevalence of OA in non-weight bearing joints. And we'll talk more about that in the future. But contemporary research has replaced this. OA is not a passive degeneration. It's an active and abnormal remodeling of the joint tissues driven by a complex host of inflammatory mediators. So this is a disease linked to biological age, not necessarily chronological age. And this is an essential prerequisite for modern research. It reframes OA as a complex, modifiable disease process that isn't just one thing. And this modern understanding is that OA is a disease of the joint as an organ, meaning it's a complex pathophysiologic issue resulting in joint failure where all the component tissues are active participants. So once again, it's no longer this wear and tear that, hey, you've run on this and that's why you have an issue with your knee and it's just worn through it. Like, no, it's going from just the one issue, like, hey, we've had issue with the cartilage and the bone to like the whole knee joint. There's a lot of stuff going in there, right? We have the cartilage, we have the bones themselves, we have the subchondral bone, we have the ligaments, tendons, we have all these things. It's kind of this whole thing inside there, not to mention also the synovial fluid and the synovium, all those things. So we're thinking it is a whole joint issue. So the joint is kind of an organ in and of itself, and arthritis is almost a joint failure, meaning we have all those components that are having an issue. So it's a reframe for sure, but stick with me. And so we kind of have an issue with three main key players, right? So first is the articular cartilage. So the articular cartilage is the cartilage between the bones, essentially what it is. And it isn't just passive erosion, right? That's what we used to think. It's just passive erosion, kind of getting worn down. It's actually driven by an activation of the cartilage cells, which are called chondrocytes, right? So they start to proliferate and paradoxically increase their production of the very matrix degrading enzymes that destroy them. So which is kind of unfortunate. And then so we have the articular cartilage. Next, we have subchondral bone. So the bone underneath the cartilage is not inert, right? It's not just a platform that the cartilage lives on. It undergoes pathophysiologic remodeling, including thickening, which is called sclerosis, or vascular invasion of the cartilage, and can also cause formation of osteophytes or bone spurs. And then third, we have the synovium, right? So this is the membrane lining of the joint capsule. And it exhibits a variable degree of synovial inflammation. So synovitis is when the synovium, which is kind of the lining, as I mentioned, we talk about synovial fluid, the fluid inside the joint. Synovium kind of keeps all that in there. You can then have inflammation of that lining called synovitis. And this is characterized by inflammatory cell inflammation and infiltration as the core driver of a disease. So we have a couple of things going on there. And then we also have to think about kind of a big umbrella term, right? So this biological model also explains the disease heterogeneity, right? So heterogeneity means there's a lot of different presentations. OA is kind of an umbrella term. It can be initiated by a bunch of different mechanisms like trauma, aging, or as we're focusing on today, metabolic dysfunction. So historically, we have thought, hey, OA is one disease. Like it is what it is. Like it's just caused by who knows what, like whether it was trauma or old age, like that's just what it was. We know that's very different. And so historically, we've tried to get medications, right? So disease modifying osteoarthritis drugs or DMOADs, they failed because we were trying to treat one thing. And so drugs were tested in a heterogeneous population, and a therapy targeting a bunch of different things could be very different, right? So if you're giving a medication, that would be good for post-traumatic OA, but you have people who have metabolic OA, that's probably going to fail, right? That cohort is not going to have good results because that's not what we need. And so just taking a step back here, you might be like, Jordan, what is post trauma OA? We see frequently people who've had trauma to their knee, specifically like in my world, in the sports world, when you have like an ACL rupture, a lot of times you have for sure like a bone bruise on your bone, or sometimes you have a little fracture as well. But that trauma later in life shows up a lot of times with early arthritis. Whether you broke your leg or whatever, if you have disrupted the joint surface somehow, a lot of times later in life, you have arthritis. That's kind of what it is. So that's post-arthritis. Then we also have age-related and then this metabolic one. So there's different slices of it. And I'm sure inside of that, there's even more. I'm learning more and more about this, which has been really fun and fascinating, but there's more to learn. But OA is not just OA. It's not just one simple thing. And within this whole joint model, local inflammation, or that synovitis, is a central driver, not necessarily just a side effect, saying, hey, inflammation actually matters. So synovitis is present even in the earliest clinical stages of this metabolic OA. And crucially, the severity of this inflammation is directly correlated with pain, functional loss, and faster rates of cartilage erosion. So once again, kind of turning the whole thing upside down, is that inflammation is playing a big factor. We used to say, hey, it's just wear and tear, like it's not inflammation, but it is. And we'll talk about how it's a little different. It's not the same as like an inflammatory arthritis, like RA or anything like that, but inflammation is playing a factor. And so this vicious cycle, kind of how it started. It's perpetuated kind of by crosstalk between the synovium, that lining, and the cartilage. So an initial joint insult or injury, whether it's mechanical or metabolic, right? So something happens that this leads to some insult and causes micro damage, releasing cartilage breakdown products. So essentially, these are recognized as damage associated molecular patterns, or DAMPs. And then these DAMPs activate an innate immune response within the joint. This triggers synovitis. So what happens is you have some sort of insult or injury or metabolic problem that leads to activation of these DAMPs. These DAMPs then trigger an innate immune system response. So we'll talk more about this later, but innate is just saying, hey, like your body's just taking care of it, saying, hey, like I'm not making new things for it, but it's like specific antibodies or antigens to it, but saying, hey, there's something going on here that's irritating. And once again, it's a vicious cycle. This inflamed synovium then synthesizes and releases a catabolic soup of pro-inflammatory cytokines into the joint fluid. And then these inflammatory mediators wash over the cartilage, shifting the balance from matrix repair to matrix degradation. They stimulate chondrocytes, which are the cells that make the cartilage, to overproduce proteolytic enzymes. And these enzymes then degrade more cartilage, releasing a new wave of DAMPs, which further amplifies the inflammation and perpetuates this kind of destructive pattern. So stepping back here, we have, unfortunately, inflammation begets inflammation. When you get angry and irritated, it kind of leads to this cycle. We're trying to fix it, but then we can't. And we can very, very similar to heart disease, right? Inflammation kind of triggers this whole response. Then we bring more things there to try to help, but it actually makes it worse. And so we kind of have this circle of inflammation going on, this vicious cycle. And there's also a distinction we need to make. As I mentioned, the inflammation in osteoarthritis is innate in the immune system, right? So it's innate. And inflammation in terms of RA, very different. So autoinflammation driven by these DAMPs is an innate one. It's just going to happen carefully. This is different from the adaptive immune system or an autoimmune attack seen in things like rheumatoid arthritis. So this explains why many anti-inflammatory drugs successful in RA have yielded disappointing results in OA. They are not the same type of inflammation. We have different inflammation. And you might be saying, Jordan, this is way over my head. Don't worry, it's way over my head too. But I'm learning more and more about this. But just understanding that there are different levels of inflammation and different levels of immune response. So autoinflammatory process driven by OA, this is not an adaptive response, meaning adaptive means like your body learns, hey, that is actually like foreign. That's harmful, even that's yourself. They're saying they recognize that as like, whoa, that is foreign. That's not what's happening in this. We're just getting inflammation, but not like attacking it. Whereas RA like aggressively says like, that is foreign. That is not mine. What's going on? And then we aggressively attack. That's why we see such erosive lesions in RA or things like that, where people are degrading the actual joint because your body's attacking it. So that's not the case here. We're not like attacking the joints. We have inflammation, but it's not quite the same. So I just wanted to clarify that when you're like, Jordan, you said inflammatory. Does that mean it's RA? No, that's not the case, but nuance here. That's the whole thing. And talking about this catabolic soup, there's a lot of words that are going to be on the slides, and there's a lot of acronyms and stuff. They're not that important. It's important to understand we do have pro-inflammatory cytokines. So cytokines, inflammation go hand in hand. The most important ones we typically see are IL-1 beta, TNF alpha, and IL-6, and they potentially upregulate destructive enzymes while blunting the chondrocyte's natural repair pathway. So we are increasing inflammation and decreasing our natural way to repair. So double hit, not good, but it's not really important to what you see, but it is worth mentioning if you are up to date on like understanding autoimmune medications, they target some of these things. So TNF alpha inhibitors, IL-6, IL-17, all these different inhibitors they have, you can target these specific cytokines. And so that's just something worth mentioning. Those are usually inflammation. And there are also other proteolytic enzymes, which I'm not going to go into. It really doesn't matter. I threw them up here for completeness, but we're talking about MMPs and aggregases, all these things that are important. Long story short, this catabolic soup is leading to inflammation, and that's ultimately not a good thing for us. And so this inflammatory milieu also provides a kind of critical answer to one of the most common clinical puzzles that we see, the disconnect between clinical radiographic findings and patient symptoms. We see this all the time where we'll get x-rays and x-rays show not a lot of anything, like maybe a little of arthritis, but nothing bad, but patients are in a crazy amount of pain. It's kind of been a head scratcher for me personally. And so this is kind of a cool tie between there. The idea is that cytokines like IL-1 beta and TNF alpha are actually pro-analgesic. So they directly generate pain by sensitizing sensory nerve endings. So sensitization is a process where you essentially become more heightened to pain. So these cytokines may increase your pain, the way you're sensing it and feeling it, which I thought is super fascinating. And so therefore, a patient's pain level often correlates more closely with biological activity of their joint than with the structural damage visible on x-ray, right? So acute flares of OA are more likely to be potentially driven by the cytokines than necessarily anything going on. So that's kind of been a big game changer for me. A lot of times I see patients and once again, get the x-ray and you're like, it's not that bad, but they're in a crazy amount of pain. Maybe because these cytokines are sensitizing to that. So this sensitization leads to increased pain and perception of pain. And yeah, really interesting. Something that this has never been taught previously in terms of how we learned OA initially. And so we're learning more about this. Very fascinating. And it kind of does help explain why we see what we see clinically, despite, once again, radiographic findings maybe not being there. And now we've kind of briefed on that. I do want to talk about more of this inflammation. So that local inflammation we talked about doesn't exist in a vacuum. It's profoundly influenced by systemic processes, particularly patients' metabolic health. That's a big thing. So the bridge connecting this systemic metabolism to joint failure is called potentially meta-inflammation. So meaning inflammation, and meta is the kind of like intertwine and related to it. So that's what we're looking at. And so what is meta-inflammation? This is defined as the chronic low-grade systemic inflammation that is a direct consequence of metabolic dysregulation, namely metabolic syndrome, right? So it's fueled by the continuous release of pro-inflammatory mediators from metabolically active tissues, primarily abdominal adipose tissue, right? So these circulating mediators create a body-wide low-grade inflammatory state that contributes to damage in numerous peripheral tissues, including the articular joint. So once again, we've talked about it before, adipose tissue is not passive, and it's not just there hanging out. Like you don't just have adipose tissue. It is metabolically active. Very important to understand that. And this systemic link has allowed researchers to identify and potentially define a distinct metabolic osteoarthritis. So it's a different subclass of osteoarthritis. It's a specific phenotype. And the clinical definition of metabolic osteoarthritis is a subtype often affecting patients in the age range of 45 to 65. It typically presents as generalized OA, which means affecting multiple joints, and is strongly associated with being overweight or obese and having at least one component of metabolic syndrome. So metabolic syndrome, we talk about central obesity, hypertension, dyslipidemia, hyperglycemia, something like that. And the epidemiologic proof is growing. It's pretty cool. The odds of developing OA increase with each additional component of metabolic syndrome a person has. So this is what we call dose dependent, meaning the more of these risk factors you have, the higher the chance you have of having OA. And so this dose dependent relationship strongly implies a potential causation here, saying, hey, there's a link here that's going on. Next, I want to talk about the smoking gun or the non-mechanical link of OA. So the most conclusive evidence that OA may have a metabolic component is the strong, well-established association between obesity and metabolic syndrome and the prevalence of hand OA. So hand OA is something we see all the time, right? The hands are typically not weight-bearing joints, right? Most people aren't just running around. And so if it's not weight-bearing, this association cannot be explained by a mechanical load, right? The old theory that we had was, hey, wear and tear, what's going on when your hands aren't weight-bearing. Some people may say, oh, it's because I typed a lot. Like, well, that's not really putting a whole lot of stress on the joint, is it? And there's tons of people who don't get OA in their hands, but type a lot. And so it kind of gave us this in-between there, which is kind of interesting. And it kind of serves as proof, really. I mean, I guess kind of the proof that, hey, this is a systemic disease, a metabolic disease, and inflammation is driving this joint disease, not necessarily wear and tear or, just going through, big loads going through the fingers, because that's just not the case. And so this is kind of a nice one to say, hey, like, what ties this all together? And this is a good one saying, hey, we see people who have metabolic syndrome have high incidence of hand OA. And so it can help tie them together. I thought was kind of interesting. And this kind of brings me to another point that body composition is really important and that mass is not just mass, right? One review that I looked at mentioned that an individual is not carrying 20 kilograms of inert fat, right? They're actually carrying 20 kilograms of metabolically active tissue that is producing inflammatory molecules, and it's just not inert, right? It's not just sitting there doing nothing. There's been studies looking at this, that this metabolic OA phenotype actually seems to be worse than other phenotypes of arthritis. It's associated with the highest levels of pain and functional disability, the most prevalent clinical synovitis, and the worst quality of life. And so all arthritis is not the same, and then all body composition is not the same. So this is why we really, really importantly want to focus on body composition and decreasing the amount of adipose tissue we have in our body. And so the role of obesity is actually like a double hit hypothesis. So you have increased mechanical load, first of all, and that's applied through the joint that's already been vulnerable, right? So it's vulnerable because of this low-grade systemic inflammation that makes the joint environment not ideal for adding on extra weight. And that's what's happening. Adipose tissue, as I mentioned, is a potent endocrine organ that secretes inflammatory signaling molecules called adipokines. So we have that. On top of that, we also have leptin. Leptin in healthy individuals helps regulate energy. In obesity, we tend to have higher leptin levels, and it becomes pro-inflammatory, leading to a catabolic situation. So high leptin levels directly instruct chondrocytes, which are the cells inside the cartilage, to increase their expression of catabolic factors, all the bad things that we do not want to happen. So we have more load and a worse general environment inside the knee. That's what obesity can do, and that's not helpful at all. Next, let's talk about type 2 diabetes and how it is an independent risk factor for OA progression proven in non-weight bearing joints. We mentioned before, right? Like hand joints, people with diabetes tend to have an increased risk of having there. So why does this happen? Well, mechanism number one is hyperglycemia and AGEs. So sustained high blood glucose or hyperglycemia, when your blood sugar is really high, it forms this toxic environment and leads to toxic compounds called advanced glycation end products, or AGEs. And AGEs are one of the reasons why we care so much about blood sugar, right? So if you have AGEs in your eyes, you get retinopathy, you can get your heart, and you get heart disease, all these things. We do not like these. And so you can get these also in your joint. And then these AGEs that we talked about, these can accumulate in the cartilage and form a direct protein crosslinks with collagen. And this makes the cartilage stiffer, more brittle, more susceptible to mechanical failure. On top of that, these AGEs also have an inflammatory effect. They can bind to their receptors called the RAGE receptor. Love that. It's a great name. This RAGE receptor is on the chondrocytes and activates pro-inflammatory pathways, and it triggers production of TNF alpha and MMPs, which are not good for the joint. The second mechanism is talking about insulin resistance and loss of protection. So joint tissues can become insulin resistant, just like the rest of our body can. Insulin is normally an anabolic or pro-building signal and a negative regulator of synovial inflammation. But when the synovium becomes insulin resistant, this natural brake on inflammation is lost. And on top of that, mechanism 3 is that we can have the convergence of the mTOR pathway. So this is a crucial deep dive mechanism. I talk more about mTOR and other things as well. But in people who have hyperinsulinemia or insulin resistance, high levels of both leptin and insulin converge on a single intracellular signaling hub. And that's what we're talking about with this mTOR pathway. And mTOR is a very, very important thing to talk about. As I mentioned, high leptin levels activate mTOR signaling pathways. High insulin levels also activate mTOR signaling pathways. And so this is kind of once again, another double hit, which double hit's never good, right? You don't have a double hit, but we have two things that are increasing mTOR activation. And activation of mTOR potently inhibits autophagy. So autophagy is the cell's essential, it's a garbage disposal system, right? So it kind of removes damaged proteins, dysfunctional organelles, it kind of cleans things around. So by shutting down autophagy, the leptin and insulin convergence cripples the chondrocyte's ability to self-repair, right? So we were saying, hey, I want to clear this stuff, but I can't. And this leads to an accumulation of intracellular debris, cellular stress, and a shift towards more cell death and ultimately accelerated cartilage degeneration. And that's like ultimately what we think is happening there. Another mechanism is dyslipidemia or chondrocyte lipotoxicity. So I love talking about lipids. That's my favorite thing. I keep learning more about this, but ectopic lipid or fat deposition in the chondrocytes themselves can initiate OA development. So this chondrocyte lipotoxicity idea thinks that we can aggravate OA by impairing autophagy once again. So autophagy, we're saying, hey, when we have an abnormal amount of fat inside the joints, that can lead to decreased autophagy, which we mentioned is very important. On top of that, we also have issues with hypertension. So hypertension may lead to something called subchondral ischemia, and it's strongly linked to knee OA, even after adjusting for BMI, right? So the mechanism we think is that it could potentially have a vascular role, which is really kind of cool and interesting. And it's proposed to cause subchondral ischemia. Specifically, what's happening is you episodically reduce blood flow to the small blood vessels in the bone directly beneath the cartilage. And this potentially could starve the avascular cartilage by impairing nutrient and gas exchange and can lead to the bone cell death, reducing mechanical support and overlying cartilage, like just structure itself. So kind of interesting. And on top of that, there are also peripheral complications, right? So type 2 diabetes contributes to destructive neuromechanical feedback loops. So think about diabetic neuropathy, right? So peripheral neuropathy, which is severe nerve damage, it's common and also linked to OA as well. And neuropathy causes a loss of proprioception, or the kind of way you sense your position or joint position, and a loss of protective pain sensation. And this impaired sensation, often combined with muscle weakness because you're not moving as much, leads to potential joint instability. And then, the patient unable to properly feel pain or joint position perpetuates, kind of leading to potentially constant harmful mechanical overload, meaning like you're not working quite right. It can lead to repetitive microtrauma, which may potentially accelerate the underlying biological degradation. So that was a lot. I will admit you there. So we step back though. Type 2 diabetes, not good to have, and it can directly affect our joints and joint health. So that's like the big thing. That was there for completeness, just because I want this to be a good resource for people who are interested in this. If your eyes is glazed over, that's cool. I totally respect that as well. I understand this is a deep one. Hang with me here, but it's very interesting that hyperglycemia and hyperinsulinemia can play a direct health factor on your knees or your joints in general, which I thought was really, really fascinating. And as if we weren't getting nerdy enough, we're going to talk about the gut joint axis now. So metabolic drivers, we just talked about, they're very interconnected and influenced by lots of things. And specifically, one of them is the gut microbiome, right? And so there's the idea that, we've heard about the gut brain axis. Now there's a gut joint axis, which provides a potentially unifying theory that connects diet, metabolic dysfunction, and systemic inflammation. And once again, this is going to get very theoretical and nerdy. You have been warned, but for completeness, I want to just have a podcast out there that's just like a deep dive on this stuff so you can go to town. And so first, we need to talk about gut dysbiosis, which is, quote unquote, an unhealthy, imbalanced gut microbiome. And in studies, they've been shown that people who have OA have different levels of gut microbiome. That's essentially what it comes down to. And they think that this dysbiosis can compromise the integrity of the intestinal barrier, leading to gut permeability, or what people know as leaky gut. And this breach potentially then allows bacterial components, most notably lipopolysaccharide or LPS, which is an endotoxin, to leak out of the gut into systemic circulation. And then this circulating LPS is a potent driver of systemic low-grade inflammation, directly fueling the meta-inflammation state we talked about before. And that was a lot. We're still learning so much about what is quote unquote normal, right? So what is normal gut microbiota? I have no idea. And so like most of this is kind of proposed saying, hey, like we saw these dietary, these changes in the gut microbiome and people who had OA. So like, therefore this could happen. And so once again, this is very like theoretical. The one piece of advice I have is if someone tells you they're a gut health expert, you probably should run from them, because like nobody understands the gut. Even like the experts who listen to them talk, they're like, we're learning more every day. And so it's complicated. Definitely plausible that there's a connection, and it's cool to see the proposed mechanisms, but this is not one where I'm like, if I just give you lactobacilli, that's going to help your joint pain. Like, we're not there yet. At the end of the day, it's probably much, much, much more complicated than that, but it's kind of cool to see. And so once again, we have another proposed 2-hit model here for everything. That seems to be the thing, but how and why OA pathogenesis happens with the gut, here it is. So first, the one is priming, right? So circulating LPS from the gut acts as a systemic danger signal, right? So kind of priming the body's entire innate immune system to say, hey, something's going on here. Like, we're not going on. And then we have this second hit, right? Which is the activation, which is where those local damps from the minor cartilage breakdown in the joint then trigger this primed and overreactive immune system, which responds with a full-blown inflammatory response, leading to accelerated structural damage. And so once again, this is local inflammation. So this is not systemic inflammation, meaning like we're having RA. They're saying, hey, this is your kind of response to this. So this is not adaptive. So that's once again 2 different immune pathways, but it's still immune related, but not necessarily like your secondary one where you've built auto antibodies to it like that. So, but you are understanding that, hey, it leads to this potential irritant going around, and then the damage already in the joint leads to more inflammation. And once again, just a cycle of more inflammation. That's kind of interesting. And this is Also kind of interesting, and there's been a newer study in 2025. This is not about necessarily just the bad signals, right? So the LPS, but it can also be the absence of good signals like anti-inflammatory short chain fatty acids. There's been research here in 2025 that has identified potentially hormonal pathways linking the gut, its metabolites, and joint health, and it provides a specific explanation for how gut dysbiosis directly causes a loss in chondroprotection. So saying that, hey, the gut is directly linked to that. Once again, we're learning way more about this now. I'm not going to say too much about it because it's still going there, but there's a lot that's going on. And so what does this cascade potentially look like? Well, in one study they looked at, they showed that OA patients were found to have altered bile acid metabolism. Specifically, and they had a significant reduction in something called GUDCA. And so this reduction is linked with lower abundance of gut bacteria responsible for producing the precursor. And so the GUDCA's normal function is to inhibit a receptor in the intestinal lining called, doesn't really matter, farnesoid X. And then what they find is that in OA, low levels of this GUDCA mean that the farnesoid X receptor is disinhibited or overactive. And then overactive FXR signaling prevents the proliferation of L cells. What are L cells? You're saying, okay, Jordan, you just said a lot of words, but what's going on here is we have a decreased production of this GUDCA. This is linked to, lower abundance of the bacteria that produce this precursor, right? And so all these things happen and lead to decreased proliferation of L cells. And L cells are probably something we've heard about before. So this is kind of a critical step. L cells are the body's primary source of the critical hormone GLP-1, glucagon-like peptide 1. If you've listened to this podcast, you know that I've mentioned that ad nauseum. They're the hottest thing right now in all of pharmacology, but very, very important. So therefore, though, what we're seeing is that the cascade of this gut dysbiosis leads to systemic deficiency in GLP-1. And why does this matter? Well, GLP-1 actually seems like it may be chondroprotective, which is crazy, right? So what happens is GLP-1 travels through the bloodstream to a joint where it binds to GLP-1 receptors on chondrocytes, or the cells of the cartilage, and synovial cells, suppressing inflammation and protecting cartilage. So this gut-joint axis mechanism is a unifying theory, right? It kind of connects the diet and gut microbiome, which once again is used to produce those GODCA, which help us get to the L cells, which help us get to GLP-1. Once again, a lot going on here. But this gut joint axis, if there's an issue going on, can lead to downstream issues of a low GLP-1, which may provide a potential rationale for why OA may in part be a disease of inhibited GLP-1. There's a lot of things and a lot of reasons. Once again, it's not, oh, you're GLP-1 deficient, but you may have decreased GLP-1 in OA, which is kind of interesting. And so there's this new paradigm, right, of metabolic osteoarthritis, and it's inflammatory, it's metabolic, it's gut driven, and there's lots of stuff going on. Well, what's this mean, Jordan? What does this mean for translating this to practice in the future? Well, I'm glad you asked. That's what we're going to talk about today. So in the metabolic osteoarthritis model, lifestyle interventions are not just like supportive cares anymore, right? It's not just like, do them because they're generally good, which is still good to have, but they are biologically active therapies that directly target the root cause of this meta-inflammation, right? And the goal here is to reverse this meta-inflammation as much as possible, right? If we think we now have an inflammation problem, a process driven by inflammation, then the treatment should be to stop that inflammation at the source potentially and go from there. So we have always recommended lifestyle things. So exercise and nutrition, all those things are very important and good, but we never really understood why. We thought maybe it's because of weight loss, and weight loss is helpful or just seems to be good. But now this kind of gives us unifying theory as to why it would be so beneficial, because it gets to the core of the issue, which is that meta-inflammation. On top of that, we need to talk about diet, right? So the primary goal is to reverse that meta-inflammation, right? So we can do that a lot of times with diet, or at least make a big dent on it. I'm not here to say like you're going to automatically fix everything with diet, but diet can make a really, really big impact. The one that's probably most studied overall is the Mediterranean diet, right? It's probably the most studied low inflammatory diet. Adherence is associated with lower OA prevalence, reduced pain, and reductions in systemic inflammation biomarkers like IL-6, IL-1 beta, and all those things. So lots of going on. And then on top of that, we've also seen there's been programs called the Plant for Joints. It emphasized a whole food, plant-based diet, and also demonstrated significant reductions in stiffness and pain for patients with metabolic associated OA. On top of that, exercise, I'm always going to say exercise is just good. It's just great for you. It's safe and effective and should be a core treatment for pretty much any condition out there. And the benefits are huge, right? They're metabolic. They're not just mechanical. There's lots of things going on. Exercise inhibits inflammation, promotes the metabolism of adipose tissue, modulates autophagy and chondrocytes, which kind of counteracts that potential mTOR pathway, prevents muscle atrophy to improve joint stability, and has been shown to favorably modulate the gut microbiome. And so exercise is good for everything. I've said that all the time. So exercise and diet are like really truly the staple of OA, which is kind of interesting. A lot of times now that's not talked about, and I'm guilty of that as well. for a long period, saying, hey, like we don't talk about it too much because we don't know. Now it's like, okay, the evidence is starting to come there where talking to them, not talking to them about them, I feel bad about it, right? So we have all this evidence that says, hey, we have these things, and maybe it's not as robust as like enormous amounts of RCTs, which I will admit, this isn't like screaming, knocking on the door with like meta-analyses and RCTs, but like these mechanisms are possible. And like right now our treatments are like, oh, do you want an injection? And so we have this option here to say, hey, here's a pretty much no risk intervention, not no risk, but very low risk intervention. That's cheap, exercise and diet change. We should be offering that. So that should be number one that we're talking about. And then what about pharmacology though, right? So there's always gonna be things that we are looking for, and diet and exercise are wonderful, but sometimes it's not enough. And so there are definitely drugs that we're looking at thinking how we can use for OA. First is an oldie but a goodie, metformin. So metformin is an anti-diabetic medication. It activates something called AMP kinase. And then this reduces meta-inflammation, improves insulin resistance, and modulates chondrocyte autophagy. So there was a 2025 GM RCT found it reduced pain in overweight and obese MetOA patients, but the effect size was modest and didn't meet the minimum clinical important difference. And so it didn't necessarily hit that. And so they say, hey, we need larger trials. That's one thing we think about. On top of that, we can talk, and we mentioned before, the GLP-1 agonist, right? So things like semaglutide, tirzepatide. This is going to blow up if I had to guess. If I was like, hey, what's going to happen? I think this is going to be a big thing. A lot of times what's happening, these are prescribed for patients who are struggling with obesity, right? Who have excess adiposity, more adipose tissue. That then leads to losing weight. And losing weight is good because, right, what are we doing? We're decreasing the amount of adipose tissue we have, decreasing that meta-inflammation. So that's beneficial. But also that GLP-1 inside the joint may be playing a factor as well. And so these are going to be really, really powerful, a cool tool. It's not necessarily approved for them quite yet for that reason. There have been RCTs about this. We've seen it worked well. So I think down the line, it'll get there. Do I think it'll ever be the first line for OA? Not until they become cheaper, but it's cool to think about. We might have additional options as well. And so once again, just to review, how do these GLP-1s work? Well, first of all, they're a potent weight loss medication, so it reduces the mechanical load. I'm not here to say that there is no point or purpose to talk about mechanical loads. There definitely is. I think a lot of times, the old mechanical model of like wear and tear, or like you hurt because this X-ray shows this, like that's been proven to be not right, but also like it's still really important, right? So if you have structural issues or mechanical loading issues, like that can lead to pain. And so it's a part of that bigger biopsychosocial thing and understanding metabolism now. So there's lots going on, but mechanical load can play an effect. GLP-1s really good at losing weight, so that may be helpful just in and of itself. But directly, you have to think about they also bind onto receptors in the joints themselves, acting as direct anti-inflammatory, anti-apoptotic, and anti-catabolic agents. And so that's one way. On top of that, it also may help the gut-joint axis. It could be a replacement for the missing GLP-1 signal that's happening on here. There was a study done in China that showed patients with type 2 diabetes and MetOA, when they used GLP-1s, it was associated with lower incidence of knee surgery and slower cartilage loss, which is pretty cool. And once again, as always, the key challenge is how do we separate this with massive weight loss, the benefit of that versus direct chondroprotective effect? We don't know, but we've already seen this has been working in the literature, but we'll see more and more about this, which will be really cool. Another class of medications that people are talking about using are something called senolytics. So an example for that would be denacinib or tyrosine kinase inhibitors. And these senolytics, they selectively kill senescent chondrocytes and synoviocytes. So when I talk about senescent, that means essentially the zombie cells, right? Senescent cells are just there hanging out. They accumulate with age and contribute to inflammation and age-related disease. And these medications could potentially halt their secretion of toxic inflammatory cytokines, and that could be very helpful. And there have been some preclinical studies that showed that denacinib plus a combination of denacinib and some sort of supplement was primarily an analgesic, which led to pain relief, but didn't necessarily modify joint structure. It worked by reducing nociceptive nerve fibers. The road is still very, very early in this, but the idea is that, hey, for those potentially who do not have metabolic associated one, just have like OA actually, like could we put something in there that kind of helps stabilize that knee joint that's already an issue? So that's something they're looking at there. And there are issues though. So a major hurdle is that there's no serum blood marker that's proved diagnostic so far for OA, right? So, hey, let alone specifically metabolic, the subtype. Like we don't have a blood marker that says, yep, you have OA. And this is a huge gap, right? So to successfully run clinical trials, researchers must be able to stratify patients and enroll only those who have a specific phenotype the drug is supposed to treat, right? So the lack of these modifying arthritis drugs is likely in part because early trials are run on unphenotyped populations. So for example, a trial run for an anti-IL-1 drug would be expected to fail if 80% of the subjects had non-inflammatory post-traumatic OA, right? So we have different ones. So we really have to get behind how are we treating them? Which subset of OA are we treating? I'm hoping this expands because, it's a debilitating disease for a lot of people. I'm optimistic for it, but we'll see. And so I do want to bring this all home here and understanding arthritis. This is a long one. I understand this is long because this is my world's colliding here. I love metabolism. I love metabolic health. I love sports medicine. So this is just the perfect nerd sauce for me. And I love it. And if you're with me, you are a true champion for this. That's for sure. But looking at it, we're transforming from the archaic wear and tear model that's gone, right? It's replaced by this new understanding that is much more biologically active. Is it everything that I say it is today? Not necessarily. This is kind of cutting edge stuff and what we've seen, but we know for sure it's no longer just wear and tear. It is thinking of it as a whole joint failure, I think can be very helpful. And so the biggest and newest thing that we talked about is this idea of the metabolic osteoarthritis, which is a condition driven by not the mechanical load that we thought about, by much more than that, by systemic metabolism, inflammation, and oxidative stress kind of environment. And so this environment originates from metabolic syndrome, obesity, and gut dysbiosis, which then creates meta-inflammation. And this systemic state attacks the joint through multiple different pathways, whether it's adipokines, cytokines, AGEs, ischemia of the bone, multiple different ways. We just learned that having this metabolic OA is a much more active process than we'd previously thought. The next big thing that we talked about was this gut-joint axis. And it's big because it provides a potential unifying mechanism for everything, right? Linking gut dysbiosis to both systemic inflammation, when we talk about release of things like LPS, and then also a chondroprotective hormonal deficiency of GLP-1, right? And so we're going to learn more about this. How do we treat that? I don't know. We still just do the overall things that we know are beneficial. Is getting a gut microbiome test helpful? Probably not at this point for this, but it's something along the way that we're going to learn more and more about, but a new concept that I want to just take home. And then what are we going to look for in the future? So I want a key takeaway to be this. The future of arthritis management is going to be phenotype specific, I think, in my opinion. So the €50 quest of finding the single magic bullet for a medication that works for all OA patients is probably over, as it was based on the false premise and a bad mechanism. So we thought that OA was a single disease. We know it's not. And so the future of the field lies in precision medicine, right? So we're going to integrate genetic data, gut microbiome data, your personal injury history, phenotype, all those things. We're going to work together to try to figure out and treat your specific phenotype. I think that's kind of where we're going from here. We're not there yet. And so we just kind of do the best things that we have, meaning, hey, health promoting diet and exercise and injections as need be and all those things we can do. But really kind of understand this is going to be not just one disease. You have OA. That's what we're going to do. It's going to be a big treatment from there. And so in this new era, a patient with metabolic OA may receive a targeted metabolic intervention, maybe like a GLP-1 agonist or metformin or Mediterranean diet, something like that. But on the other end, we'll have someone who has post-traumatic OA who maybe will receive a local senolytic injection or something like PRP or anything like that. And so this is kind of understanding that the future is going to be very personalized, I think, for OA, kind of looking at people, understanding where does it come from and treating them differently. And like most things, everyone's different. No one's going to respond perfectly to one thing. And one thing's not going to work for everyone, but hopefully we can kind of stack them together. And I hope that this was helpful for you. I know this is a long one, a deep one, a nerdy one, but this is a new concept and a potentially revolutionary concept. And that's why for me, when I was reading this, I got so excited because this changes everything. How we've previously treated disease has completely changed. And I think that's really important to mention. But that is going to be it for today. Thank you so much for stopping by. If you did enjoy this though, and you stuck all the way, it means the world to me if you either share this with a friend, left a 5-star rating on your podcast platform of choice, or subscribe on YouTube. Now get off your phone, get outside, have a great rest of your day. We'll see you next time.